Evening, good afternoon, wherever you are around the world. Welcome to the ILAE Africa EpiSkills webinar. And this evening, we will be talking about the IGAP projects that are happening in Africa. This evening, we'll be covering 3 projects, fantastic projects that are happening as part of the IGAP project that's happening in Africa. And hopefully this project will stimulate discussion among the participants in this webinar, talking about other fantastic projects that are happening around Africa. And to start with, let me introduce myself. My name is Edward Kija. I am the pediatric neurologist from Muhimbili University in Dar es Salaam, Tanzania. And I'll be the chairperson for this session. And with me, I also have my co-chair, Dr. Nalucha from Zambia, as well as 3 fantastic speakers, Professor Charles Neutron, Professor Ed Traven, and Dr. Mfwama. So to start the session, our first speaker who will introduce the IGAP projects. It's my pleasure to introduce Dr. Nalucha, who is an adult neurologist from the Levi Mwanawasa University Teaching Hospital in Lusaka, Zambia. She's also a Secretary General of the ILAE Zambian chapter and also the Young Epilepsy Section Africa representative. So without further ado, let me welcome Dr. Nalucha for the first talk. You're welcome, Dr. Nalucha.
Thank you, Edward, for that wonderful introduction, and good evening to everybody who's logged in. Thank you for logging in. So my task for now is very simple. Just to give an overview of what the IGAP is, looking at the theme of our webinar this evening. So IGAP stands for Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. So just a background on this. So in November 2020, the 73rd World Health Assembly adopted a resolution on global actions on epilepsy and other neurological disorders. And this was to address the challenges and gaps in providing care and services for people with epilepsy and other neurological disorders, and to also ensure a comprehensive coordinated response across all sectors. So this was approved by all the World Health Assembly member states. So what exactly is IGAP? So it's a 10-year goal or roadmap from 2022 to 2031, which was launched by the WHO. And it's mainly to effectively address neurological conditions and to also improve lives of people with epilepsy and other neurological conditions globally. So it consists of 5 strategic objectives, and each objective has 2 targets, so a total of 10 global targets. And this is to reduce the stigma, impact, and burden of neurological disorders, and to also improve the quality of life of people with neurological disorders, their carers, and of course, their families. So when this was introduced, the ILAE and the IBE advocated for a 90-80-70 casket target for epilepsy. So 90% of all people with epilepsy are aware of their diagnosis as a treatable brain disorder. So this is just through increased public and professional awareness about epilepsy, also improved diagnosis through training and enhanced specialist networks, and also to replace the myths, especially the harmful ones, with an understanding that epilepsy is a treatable brain disorder. And we're looking at 80% of people with epilepsy have access to appropriate, affordable, safe anti-seizure medicines. So this is through sustainable and strengthened medical supply chains, and also looking at the affordability of anti-seizure medicines, and also reclassification of certain anti-seizure medicines to allow production and importation. And then the 70% of people with epilepsy on treatment achieve adequate seizure control. So mainly it's through our investment in primary and community care and support, and people with epilepsy should be informed and engaged and also empowered. So this is a World Federation of Neurology diagram illustrating the strategic objectives of the IGAP. So like I had mentioned, it has 5 strategic objectives with global targets. And the one that is epilepsy specific is objective number 5, which is to strengthen the public health approach to epilepsy. So the global target 5.1, so by 2031, countries will have increased service coverage for epilepsy by 50% from the current coverage in 2021. And the other target is that 80% of countries will have developed or updated their legislation with a view to promoting and protecting the human rights of people with epilepsy by 2031. Now, this is epilepsy specific objective, but then all the other target areas are still relevant to epilepsy because they deal with government support and policy direction. So the proposed actions are in this IGAP with relation to epilepsy is that there needs to be access to epilepsy services. So we know that with anti-seizure medication, up to 70% of people with epilepsy can become seizure-free. But we have treatment gaps that exist in countries, and these vary. And they're higher in actually the low middle income countries, especially in Africa. So the current treatment gap estimate is 75% in lower income countries, and it's higher in the rural areas. So the other action is actually engagement and support for people with epilepsy. And this ties to stigma and discrimination of those who are living with epilepsy, including their families. So we need to break down these myths because there are a lot of misconceptions and negative attitudes that lead to this stigma and discrimination. And eventually there are a lot of human rights violations and social exclusion in some settings where you find that maybe children with epilepsy may not be allowed to go to school, and other myths to say they may not marry, they may not live a normal life, and also employment becomes a challenge. And then the other one is make epilepsy as an entry point for other neurological disorders. So we know that there are other neurological disorders which epilepsy can result from, and such as stroke or traumatic brain injury, and also adults with epilepsy may also have intellectual disabilities. So these are the proposed actions. And with this global action plan, it will help to strengthen the prevention, detection, care, and treatment and equal opportunities for people with epilepsy and other neurological disorders worldwide. So just to acknowledge ILAE Africa for setting up this EpiSkills webinar where we're able to look at the different projects that are taking place on the continent. And for those who'd like to learn more about the IGAP, you can check for it on the WHO website or the ILAE website. Thank you so much. And with that, I'd like to introduce our speaker, Professor Charles Newton. So he's a pediatric neurologist by training with over 30 years of experience in conducting neurological studies in East Africa. And for the last 20 years, he has conducted large-scale epidemiological studies of people of epilepsy in 5 countries in Africa, including Kenya, where he has been working in a rural area. He has also been involved in examining treatment gap and stigma associated with epilepsy and adherence to anti-seizure medication across Africa. He has also been involved in the recently published Global Burden of Disease report. And also, he is the Cheryl Andrews Scott Professor of Psychiatry at Oxford University, the past chair of the Epidemiology Commission for the ILAE, and he's worked extensively on the WHO Mental Health Gap Action Program guidelines responsible for sections on epilepsy and mental disorders. So Professor Newton has mentored more than 50 trainees at all levels, demonstrating his passion and significant interest in contributing to the development of future health research leaders in Africa, Europe, and the US. As a health services researcher with expertise in epilepsy and neuropsychiatric disorders, he has comprehensive experience using large population-based data to study epilepsy outcomes and comorbidities. He's a resident in Kenya and continues to work there. So he has the required skill set to provide the content and methodological expertise necessary to support the successful completion of the project. He has published over 400 peer-reviewed publications. And so I'd like to introduce Professor Charles Newton to give us our next talk. Welcome, Professor.
Hello, my name is Charles Newton. I'm a pediatric neurologist who's been working on the Kenyan coast for the last 30-odd years. Today, I'll be speaking about some of the studies that we've been conducting on epilepsy across Africa in the last 2 decades. Epilepsy is a major problem in sub-Saharan Africa. The prevalence is in the order of twice that in the Western countries and is higher than that in Asia. But the prevalence episodes are very wide. And what the difficulty is whether these differences are real differences or they're due to methodological differences. For example, case detection, case definition and investigations utilized. Most of the studies detect convulsive epilepsies, which represent only about half of all the epilepsies. So in 2008, we started a study which involved 5 sites spread across Africa for the SEED study, the studies of the epidemiology of epilepsy in demographic surveillance sites. And the reason that we chose those sites is because they provide accurate denominators. We're able to identify subjects for follow-up, and we were able to measure the mortality associated with epilepsy. The 5 sites were chosen on the intensity of parasitic factors because these are preventable causes of epilepsy, and also those that could provide neurological support for the subjects identified with epilepsy, and also due to cost and logistic reasons as well. This study was led by Anthony Ngugi, and we were able to survey over 620,000 people across the 5 sites. We used exactly the same methodology to determine and identify active convulsive epilepsy across the sites. And as you can see, there was a big difference between the sites, with Agincourt having a prevalence of 7 per 1,000, while that in Ifakara, Tanzania was nearly 15 per 1,000, with the other sites in between. This was despite using the same methodology, suggesting that there are real differences in the prevalence of epilepsy across the continent. As you can see from these diagrams from the individual sites, the prevalence is on the y-axis with age on the x-axis. The bars represent the age of onset, and the blue line represents the prevalence. As you can see that there are quite significant differences between the different sites, between the onset of epilepsy as well as the prevalence that occurs in these respective sites. We were particularly interested in the risk factors for the active convulsive epilepsy across the sites and did case control studies in each of the sites. The most significant risk factors were seizures within the family or maternal seizures, but also abnormal pregnancy and problems after delivery were important perinatal events. Head injury before the seizure suggested that traumatic brain injury was also an important cause. And although we identified eating cassava as a risk factor for the development of epilepsy, we think that this is a marker of socioeconomic status. What we were particularly interested in was the population refraction, a measure of the amount of a risk factor that, if could be prevented, would have a reduction in the prevalence of the condition that you are looking at. So as you can see from this diagram, from this slide, that the population of triple refraction in children of abnormal pregnancy and problems during delivery or perinatal difficulties was about 0.33 across all the sites, suggesting that a third of the epilepsy could be prevented if we could avoid abnormal pregnancies and perinatal problems. In adults, infections and parasitic diseases were more important, with an overall population refraction of 0.35, suggesting again about a third of the epilepsy in adults could be prevented by preventing infections and parasitic diseases. We also assessed adherence to anti-seizure medication across these sites. As you can see from the table, the reported adherence was in the order of 59%, while that of, as determined by detectable blood levels, was 63%. The sensitivity and specificity was in the order of 70 to 76% across the sites. Only 287 of the 101,303 samples had optimal levels, which represents a very small portion, suggesting that the treatment gap for adherence was in the order of about 78–79% across all sites. We also use the demographic surveillance system to look at mortality in Kilifi, Kenya, and in Agincourt, South Africa. This is some of the data from Kilifi, again suggesting that the increased mortality, as represented by the standardized mortality ratio, was about 3.7 times higher than that of the background population, and it particularly affected the adolescents between the ages of 13 and 17, as well as children and younger adults as well. So this led us to reformat or rethink about the pathway to care, and also to begin to quantify the different therapeutic gaps. So a person has epilepsy, may be undiagnosed. If they are, if they do see traditional healers, which most of the people with epilepsy in sub-Saharan Africa will see a traditional health practitioner before going to the biomedical facilities. These may be referred on to biomedical facilities where they will have a diagnosis of epilepsy. This represents a diagnostic gap. If they're then put onto medication and prescribed medication, but do not adhere to it, then this is the medical adherence gap. But it's also important to remember that there are other modalities for the management of epilepsy, the non-pharmacological treatment gap, which includes, most importantly, the psychosocial support, but also things such as vagal nerve stimulation, surgery, and ketogenic diets. Caroline Kafmoni used the data from the Kilifi site in order to investigate the factors associated with the diagnostic gap. As you can see, there were a multitude of factors associated with it, but the ones that occurred in the terms of the multivariate analysis, including not being a member of a formal religion such as Islam or Christianity, having to pay for anti-seizure medication, distance to the healthcare facilities, and traditional beliefs about epilepsy. She also looked at the risk factors or the factors associated with the treatment or medical treatment adherence gap. Again, there were some of these associated with the epilepsy themselves, such as the seizure frequency, injury during seizure, duration of medication, and the number of anti-seizure medications the person was on, as well as the side effects of the anti-seizure medication. But there was also, in the univariate analysis, a poor relationship with a provider was associated with a poor adherence, and again, beliefs about the cause of epilepsy. In the multivariate analysis, the only one that persisted was the negative stereo beliefs about epilepsy by the participants. So these studies that were conducted between 2008 and 2014 led to the epilepsy pathway innovation studies, which are a group of studies funded by the National Institute of the Health Research. Here we conducted studies in 4 sites across 3 countries, and the aim here was to reduce the public health burden of epilepsy in lower middle-income countries by improving prevention and the clinical management of epilepsy. In order to do that, we selected sites in which we could show that epilepsy could be prevented. We looked at disease manifestation and the prevalence in low-income countries that could form planning and policy. We improved the accessible and acceptable treatment by addressing stigma. We've used mixed methods studies in order to address these, and with the help of the World Health Organization, have conducted health system and implementation research addressing the access, cost effectiveness, and acceptance of the prevention of the available prevention and treatment programs. We chose 4 sites. One, Mahenge, because it has the highest incidence of epilepsy recorded on the continent, and that parasites probably are responsible for 60% of the epilepsy. We used Kalifi because of another rural site, because they had expertise in EEG, run a demographic surveillance site, and have a clinic of over 2,000 patients. We also chose 2 urban sites, the Nairobi informal settlements, because not much work had been done in informal settlements, and also in Accra, because this was the site of the WHO demonstration project in 2014. The EpiNo project involved 4 cornerstones, which were prevention, improving awareness, improving care, and decreasing burden. And for these, we had a matrix which looked at capacity, outcome, impact, sustainability, and dissemination in this context. For the prevention of epilepsy, we concentrated on the Mahenge site because of the high incidence of epilepsy in this site. This work was led by Bruno and Dan. As you can see, Dan is meeting up with Jalak Ali, who formed the clinic in the 1960s. This required informative research, which included a lot of ethnographic research led by Sloan Malone, and also a door-to-door survey as a background. We worked with the Tanzanian government to ensure that the onchocerciasis control program, onchocerciasis being one of the major parasites associated with epilepsy in this area, and recorded cases over a 2-year period, and we'll have a 80% powered to detect a 30% reduction in the incidence. To reduce the diagnostic gap, we worked in all 4 sites, again using informative research through oral histories, anthropological research, and in-depth interviews with people with epilepsy, their families, healthcare staff, and traditional health practitioners. We developed an app to improve the diagnosis, the Epilepsy Diagnostic Companion, and this has been work which has been led by Arjun Sen and Gabriel Jones. And also we set out to utilize EEG electroencephalography within the community so that they didn't have to come to the clinics in order to get EEG, and thus trying to reduce the time that they spent in terms of traveling for the diagnosis. So this is what the diagnostic pathway gap looks like. A person has a possible seizure, and it's important to obtain an accurate history because the diagnosis of epilepsy is made on history, and you may need appropriate investigations. What is particularly important is the cultural understanding of the seizure within the context of the community. And we've also been interested in adding video to try and record the seizure on smartphones if this is at all possible. All of this information is captured on an app, and together with the need for investigations such as EEG or ECG in order to identify whether this is really epilepsy or whether this is due to a cardiac event. And this leads to an integrated diagnostic platform, which we'll hope that we'll be able to give out for free at the end of the study. For the app in practice, we used data from over 2,000 subjects, most of whom have epilepsy. We've been using peripheral health workers to administer the app prior to the patient being seen by neurologists, and compare the diagnosis of the app with the local neurologist, and done this in an iterative process in order to improve the sensitivity and specificity of the app. We've also used data from the SEED study to develop the app, and found that the app is now able to detect convulsive epilepsies with a sensitivity and specificity of over 80%. We're using the app to integrate with other forms such as the EEG, and we're looking at ways to analyze the EEG by spike detection and software and algorithmic analysis to identify those that are most likely to have epilepsy. Again, we're comparing this to the gold standard of the reporting physician in this context in order to try and improve the diagnosis of epilepsy in peripheral health clinics and possibly within the community by using this technology. We have been improving the management of epilepsy by healthcare staff through collaboration with various different organizations across the continent in training neurologists and psychiatrists and adult physicians and pediatricians to detect and diagnose epilepsy. For primary healthcare staff, we have rolled out the MHGAP guidelines in all 4 sites, and in one site we've conducted a stepped wedge design to determine the efficacy of the training program. We chose to conduct the step wedge design trial in Kilifi County because we're able to map out all the healthcare facilities, of which there are over 80, serving a population of over 1 million people. Mary Bitter led the step wedge design, and which she's managed to train over 300 healthcare staff. The primary outcome is the number of people with epilepsy diagnosed after the intervention, after the training of the MHGAP guidelines, with secondary outcomes including knowledge and attitude of the healthcare staff, the prescription of the anti-seizure medication, and the quality of life of people with epilepsy. To reduce the adherence gap, we have been utilizing the wide coverage of mobile telephones within Kenya. and utilizing SMS to improve adherences, as has been used with antiretrovirals in South Africa. This is a randomized controlled trial which is taking place in Kilifi and in Nairobi, and sends daily messages to remind the people with epilepsy to take their anti-seizure medication. It has 90% power to detect an increase in adherence from 30 to 50%. Finally, we have been involved with implementation research using the WHO's information kit on epilepsy, targeting policy makers, healthcare providers, people with epilepsy, and non-governmental organizations and the general public. In Kenya, this has been led by Simon Kariuki through the National Epilepsy Coordination Committee, and these coordinating committees have now been set up in Ghana and Tanzania. As part of this process, we've conducted situational analysis in each of the countries, and also provided an economic analysis of the rollout of the IGAP guidelines and the SMS to improve adherence as well. This will ultimately lead to dissemination, and has already done so, with our colleagues being interviewed on local radio, television, and other social media. We've also collaborated with the Documentary Institute of East Africa in order to provide participative videos in order to look at, to examine people's experiences with epilepsy. Material has been given to the Ministries of Health and Social Services as well as Education, and we've been in collaboration with local organizations and international organizations. And of course, we've been presenting scientific papers at conferences as well as publishing them. So in summary, epilepsy remains a major neurological problem in Africa, but a great proportion of the epilepsy can be prevented on this continent. We do need to bring innovative methods to address the diagnostic and therapeutic gaps, and we are trying to do this through the apps, utilizing EEG and algorithms, and using SMS messaging to improve adherence. It is very important that we engage with public and public policymakers in order to make people aware of epilepsy, that this is a manageable condition, and that it can have a profound influence on people's lives. Thank you very much.
Hello, everyone. I think we have lost Charles' connections, but nevertheless, I think we're coming to the end of his talk. So I think, yeah, so I would now like to welcome our next speaker. And our next speaker is Dr. Edwin Trevethan, who is a professor of pediatrics and neurology from the Amos Christie Chair in Global Health. He's also working with the Vanderbilt Institute of Global Health at the Vanderbilt University Medical Center in the Nashville, United States. So I'd like to take this opportunity to welcome Dr. Edwin to give his talk on the Bridge project. You're welcome, Dr. Ed.
It's a pleasure to speak to you today about the IGAP project or program that's been initiated by the World Health Organization, and the implementation of IGAP in the context of what we're learning about bridging the childhood epilepsy treatment gap in Africa, a project that I and many of my colleagues in Nigeria are currently working on. And to a lesser degree, the context that we are now providing with another project in northern Nigeria, the Childhood Status Epilepticus and Epilepsy Determinants of Outcome Project, or the SEED project. Our research in Nigeria is funded largely by the National Institutes of Health. We've also had funding from Vanderbilt University, the Healthy Sunrise Foundation in the United States, and photographs that you'll see of children and of people in northern Nigeria are actually folks involved with the Bridge Project. Their photos were obtained and are used by their consent, given to Candor Johnson, a professional photographer and former student of mine. There are two facts that I think we need to start with that really have prompted the research that I'm going to describe, but then also I think really undergird some of the most important issues related to the IGAP proposals and IGAP goals. And the first is that, at least from the standpoint of children, in which, and I think a key issue is that about 80% of children in the world live in low middle income countries where the treatment gap is high, where the percentage of children not receiving treatment for epilepsy is high. And what we can estimate is that over half of all children with epilepsy in the world are not treated, which of course is just completely unacceptable in this day and age. And that actually what we now know from the Bridge Project is that most of these children who are not treated with epilepsy are unknown to healthcare systems. The other real challenge here, and I think also opportunity for research to play a role, is that there's more genomic diversity in the African continent than in the rest of the world combined. And in fact, it's not even close. And these are from data from the H3 Africa project, which has given us a lot of insight into the genomics of Africa. And I refer you to this article that was published in Nature in 2020. I first became aware of the great challenges of the epilepsy treatment gap almost 25 years ago, and really was influenced a lot by Henry Minardi, who I had the pleasure of knowing and working with, and he and others really brought out the issue of the epilepsy treatment gap into the public, and really made this a priority through publications in the British Medical Journal, news media, and really gave the International League Against Epilepsy an important position to address this important issue with the World Health Organization. Then there was a major step forward in spite of its imperfections, I think, in 2010, and then with a revision in 2016 with the World Health Organization's mental health gap intervention guide, and this was an issue. This was a program that addressed the epilepsy treatment gap in the context of mental health. And although this was really important as a step forward, there were several major shortcomings, and I'll just mention them briefly. The first is that the approach taken by the World Health Organization was really one that was based upon not only the failure of doing much about the epilepsy treatment gap over the previous decade, in spite of many people's efforts, but the fact that the HIV programs in Africa have been extremely successful, with community health workers taking the lead in many areas of Africa in both screening and treatment of HIV, using screening tools with blood tests, and then drug regimens in which basically everyone who had HIV got the same regimen. And that was very successful. And based on that experience, WHO recommended that epilepsy care also be, to a large degree, task shifted to community health workers, and thus the term task shifting, which forms really the basis of this MHGAP intervention guide. But there are a few problems. One is that non-convulsive epilepsies, which of course is major contributors to morbidity and mortality in epilepsy and really quite common, were completely ignored in this intervention guide. Although most people with epilepsy who are not diagnosed or treated are not really known to the healthcare system, there was really no plan for how to identify these people with epilepsy in the community. There was really no evidence that training and supervising community health workers to do this task could be accomplished. There was no real insight given as to how these people would be paid. And I think perhaps most importantly, there's really no evidence in the literature, and this continues to this day, from clinical trials that task shifting epilepsy care to community health workers is effective, or at least no worse than physician care. So there's still quite a few limits. Then I think a major step forward occurred in 2022 with the publication of the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, or IGAP. And perhaps the most important issue I think that was raised and recognized in the IGAP plan, which is summarized in this excellent, very short review in Lancet Neurology from last year that I have referenced at the bottom of the slide, is the recognition that addressing the epilepsy treatment gap would really require multiple different segments of government and of society. And it is not just a matter for ministries of health to address, but rather that there needs to be an effort from multiple sectors of government and society in order to address this critically important need. The summary of the epilepsy treatment gap is really shown in this slide, which is from the International League Against Epilepsy website, and that is their goal. It really is that by 2031, so less than a decade from now, that 90% of all people with epilepsy would be aware of their diagnosis and that it is a treatable disorder, that 80% of people with epilepsy have access to appropriate and affordable, safe anti-seizure medicines, and that actually 70% of people with epilepsy would be not only treated, but have adequate seizure control, which I think most of us in the epilepsy field would agree that adequate seizure control is essentially seizure freedom. Now, those goals are extremely difficult, and I'm very optimistic and excited by the IGAP goals, but I think it's fair to say that they will not be achieved. And I think that this slide really illustrates, or at least not achieved by 2031. And I think this slide really illustrates one of the biggest barriers, and that is the diagnosis of epilepsy, unlike HIV, as all of you know, is not from a blood test that anyone can do when they go through communities, but rather is based upon someone who actually is well trained, obtaining a history in someone's native language with a clear understanding and respect of their culture. And that's easily said, but when you realize that there are over 200 local languages in the African continent, and in fact in Nigeria alone, there are over 300 languages. And although most people can be reached with 5 languages, the nuances of epilepsy diagnosis from a history perspective really require someone having a clear understanding of the local language who's making the diagnosis, and that tools be used that are available in these local languages to assist those folks. And so this linguistic challenge, I think, is perhaps one of the greatest challenges to achieving the goal of 90% of all people knowing their diagnosis and that it's a treatable medical condition. Mali, I think, presents an example of this challenge. So Mali has about 20 million people, so a little less than 10% of the population of Nigeria, which is about 220 million. And Mali, just within its 20 million population, has 13 official languages. And that doesn't include French because most people in Mali do not speak French. It's only those with higher educations that tend to learn French, and even those people speak on a daily basis and communicate in Bambara or one of these other tribal languages. So the challenge in places like Mali is really what we've got to address. In part because of the language complications in the diagnosis of epilepsy, and also because of some other strategic advantages to doing this work in northern Nigeria, we started the Bridge Project in northern Nigeria with the intent of working in one local language that could be understood by a large group of people. So Hausa is spoken by over 100 million people, many of them in northern Nigeria. And essentially, almost everyone in this area of northern Nigeria where we work in the northern part of Kaduna State and in Kano State speak Hausa. And this area also is home to probably the largest concentration of people living in extreme poverty in the world, northern Nigeria. So the Bridge Project, funded by NIH, our current R01 grant, has three aims. The first is a non-inferiority cluster randomized controlled trial of task-shifting epilepsy diagnosis and care to specially trained community health workers. And there's 60 clusters or 60 communities in 3 cities. Each of these communities receives their primary health care at a primary health care center. And so we're conducting this cluster randomized controlled trial of the recommendation of the WHO. And then we're also studying the implementation of this task-shifted epilepsy care, as well as studying and determining the cost effectiveness of task-shifting epilepsy care to community health workers. This slide demonstrates a satellite picture of Kano, Nigeria, one of the 3 cities in northern Nigeria where we're working, and 30 of our 60 sites are in Kano. And what we did was we randomly selected, with permission and consent of the Ministry of Health and local leaders, 30 local communities within the Kano city area. And of these 30 communities in Kano, each of which where people receive care from a primary health care center, we randomly assigned half of them to task-shifted epilepsy care to specially trained community health workers, and then half to what we call enhanced usual care, which is physician care, with the added enhancement of community health workers providing assistance to families in navigating the health system. So it's task-shifted care versus enhanced usual care. And the community health workers at each of these 60 primary health care centers received epilepsy education that we piloted initially among 22 community health workers, 20 of whom successfully passed the program. And we've now completed this epilepsy education program for community health workers. We trained over 140 community health workers that are now working on the Bridge Project. The training consisted of recorded lectures that the community health workers carry with them on their tablet computers and can refer to as a reference along with notes and so forth. And then we also had small group activities that reinforced these lectures, as well as clinic experiences for all of these community health workers being supervised by a physician with expertise in epilepsy before they took on the role of caring for patients with epilepsy and making initial diagnoses as specially trained community health workers. We also validated in HAUSA this tool that we call the Childhood Epilepsy Diagnosis and Seizure Classification Tool, which actually mimics um, what we do in clinic. So there are 3 screening questions, and I'll let you just read them. Has your child ever had a seizure? Has your child had any episodes of altered awareness? Does your child have episodes of sudden head drops? And if the answer for each child screened for these 3 questions is no, then they were excluded in the next child screen. But if the answer was yes to any of these questions, then that was considered a positive screen. And then these additional questions, which I won't read, but you can scan them, were asked for the children who screened positive. And these questions really help determine whether the possible seizure is a primary generalized seizure, a focal onset seizure, myoclonic seizures, and so forth. And we found that in the validation studies we did that these questions really help guide the community health workers as they also do their subsequent clinical evaluation to determine whether someone has a diagnosis of epilepsy. Now, when we screen these communities for epilepsy door to door, they're not addresses in most of these homes. And so what we actually did was have the community health workers use this random walk method that's been developed by the WHO. And as they went from house to house, they obtained GPS coordinates on each house so that we could then locate children for follow-up and also perhaps in the future use our data to obtain other sorts of measures of environmental exposures. This is the just overall design of the Bridge Cluster Randomized Control Trial. So there's 60 communities served by primary healthcare centers that served as clusters, and we had 30 communities assigned to task-shifted epilepsy care by epilepsy-trained community health workers, and then 30 communities that were assigned to enhanced usual care or care by physicians with community health workers helping people navigate the health system. And then the goal was to enroll between 1,600 and 1,800 children with epilepsy, with the primary outcome being the percent seizure-free at greater than or equal to 6 months at the 24-month blinded physician visit. The blinded physicians were blinded as to the arm of the study that each child was in. And these are also physicians considered to have expertise in epilepsy. And you can see that there's a list of various secondary outcomes. Now, just to give you an idea of the task-shifted epilepsy protocol followed by the community health workers, they all have, as I mentioned before, tablet computers that have these protocols placed in them that help them as they go through and see patients, screen them, diagnose them, and then help guide their therapy. But the protocol is basically that if the child screens positive, they have a diagnostic evaluation. If the child is diagnosed as having epilepsy and is over the 6 months of age or older, then they are prescribed one of the 3 medications that are typically available, drugs that are a part of the essential drug list from the WHO, phenobarbital, carbamazepine, or valproate. And the decisions are made as we would make them as clinicians, as physicians, based on seizure type and other characteristics. If children were less than 6 months of age or had a diagnosis of infantile spasms made by the community health worker or suspected infantile spasms, they were sent to their supervising epilepsy physician. And if they had any questions regarding the patient's diagnosis or management, they could always consult their supervising physician. The blinded physicians then evaluated these children without knowledge of which arm of the study they were in throughout the study. The children who screened positive for epilepsy who were in the enhanced usual care arm of the study were simply referred to a physician as always. And those children were also evaluated by blinded physicians at specific times. Now, there are several aspects of the study that I can tell you about that were not what we expected. And we'll have the final results of the clinical trial later this year, and hopefully results published shortly thereafter. But one of the things that surprised us was the epilepsy treatment gap, which we estimated would be about 60%, was actually 96.5%, so much higher than we anticipated. And the enrollment was so rapid that we actually had to work to slow the enrollment down and then to equalize the enrollment across the sites in order to ensure power for the study was quite a demanding exercise because we just were not prepared for the volume of children that we would identify with epilepsy that was previously untreated in the community. Our strong community engagement, I think, also assisted with the very high enrollment rate. Now, this gives you an overview of where we are at this point with the study. We had a little less than 42,000 children who were screened. You can see the numbers that were screened positive and that were initially diagnosed with epilepsy by either the primary care physicians or physicians in the community in the enhanced usual care arm, or by the community health workers in the task shifted care arm. And that group is what we refer to as the diagnostic accuracy population. And you can see that there are children initially diagnosed as having epilepsy who, after being evaluated by blinded physicians with expertise in epilepsy, they were found to not have epilepsy and in fact have other disorders such as movement disorders, chorioathetosis, children with cerebral palsy who had tonic spasms that were really not seizures. So those sorts of children actually have occurred in both arms of the study. To date, more in the enhanced usual care arm than in the task shifted care arm. But that diagnostic accuracy evaluation is ongoing and will be important. We now have 1,680 children in the epilepsy outcomes population from the two arms, as you can see, and the results of these this clinical trial in terms of epilepsy outcomes will be available later this year. Now, from the standpoint of what we've learned in the bridge study that I think can be sort of used to inform the IGAP goals, one is that these children who do not have epilepsy are in the community, or who have epilepsy, have not been treated, are in the community, have not been really evaluated, typically most of them in the healthcare system. And it's really only through community screening and community engagement that these children can be located. And going through healthcare facilities only, going through hospitals and tertiary care clinics simply will not identify these children. And I think that's one reason why the treatment gap was underestimated in the past. Another thing we've learned is that children with previously untreated epilepsy are much more complicated than we previously realized. And I won't go through all the details on this slide, but as you can see, about 23% of the children with epilepsy in the bridge study have cerebral palsy. And that is dramatically higher than the population of children with new onset seizures in the United States or Europe having CP, and is just an example of just how this population of children with epilepsy is different than what we're seeing in the United States, and they seem to have a much higher rate of children with symptomatic epilepsy. Other evidence of that is the intellectual disability evaluation. So all the children who were 5 years or older in the Bridge Cluster randomized controlled trial were evaluated for possible intellectual disability, and children who had no expressive or receptive language at all were designated as having presumed profound intellectual disability, and they were excluded from the evaluation by psychologists and psychiatrists who did this Ravens colored progressive matrix testing for intellectual disability. And there were a large number of children who were so intellectually impaired that they could not complete the Ravens test, no matter how much instruction and time they were given. And then there was also a large percentage of children who tested at the intellectually impaired level on the Ravens test. So you put all those groups together, it's about 70% of children who are 5 years or older in the Bridge Project have some degree of intellectual disability, which gives us further evidence that this is a very complicated group of children with lots of neurodevelopmental comorbidities, and we're likely dealing with a large number of children with symptomatic epilepsies that are difficult to treat in many situations that are in this group of untreated children. Another issue that complicates children with previously untreated epilepsy is the co-association with malnutrition. And you can see that over half the children in the Bridge study have stunting, and that about 1 in 5 have wasting. So malnutrition is something that is also something that we're dealing with on a daily basis, and projects that probably can address both malnutrition and epilepsy will be very helpful, I think, going forward. One reason that stunting is important is that there are small intestinal abnormalities in essentially all children with stunting that we think could be affecting the absorption of some anti-epileptic drugs. That's not known with certainty, though, but an issue of important research going forward. Another issue in Nigeria especially is that Nigeria has a very high burden of sickle cell disease. And given the high rate of comorbidities among the children with epilepsy in the Bridge Project, we've asked the question of whether there are children with undiagnosed sickle cell who could have had strokes, and their epilepsy is in fact symptomatic of strokes related to sickle cell. So we are in the process of completing screening for sickle cell disease in the children in the Bridge Project, and we'll have those data available also later this year. Traditional medical practices or traditional treatments like herbs and prayer, other spiritual treatments are often used in these children by families. And what we've learned is that the families tend to share this information with their community health workers, but not share this information so much with physicians. And so this could be an issue for further research. And certainly the interactions between some of the herbs and traditional treatments and anti-seizure medications is largely unknown. Mortality associated with epilepsy is also unacceptably high. In the Bridge Project, mortality across both arms of the study is currently about 6% over 2 years. And most of these children had malnutrition, cerebral palsy, or both. And so there is a major component of risk related to malnutrition and cerebral palsy that is likely underlying many of these deaths. And you can see the other causes of death. We have had deaths associated with status epilepticus and sudden unexplained death in epilepsy. COVID also likely played a role in 2021, but COVID testing was not available. So the other things that we've learned is that The WHO essential drug list could probably benefit from the addition of a drug that's broad spectrum, that is safe in pregnancy, a drug like levetiracetam, and we're hopeful that that could happen in the future. And a simplified version of task-shifted epilepsy care might work better in this situation, another issue that has not been tested. Policy and at the state and national levels in all these countries is going to be important. And at some point, supply chain with strategically placed local manufacturing of anti-seizure medicines will be important in order for us to meet the demand. Further research into epilepsy genomics and I think clinical trials in sub-Saharan Africa are going to be really important in addition to managing comorbid conditions in order to eventually achieve the treatment goals in the IGAP. Finally, I'll just end with this observation, and this is a slide that I've received from ICNA with Joe Wilmshurst's blessing. And this is just a reminder that the places in the world where children are living in conflict-affected areas, war, violence, insecurity, they tend to be the same areas where there's extreme poverty, and these are the same areas where there's likely very high treatment gaps. So as we address the treatment gap in epilepsy, it's going to be important that we intentionally develop projects and programs that can be effective in conflict-affected areas. The teams for Bridge and Seed are large. There's no way to do large projects like this without a large team, and we've been blessed with a wonderful team, and I just want to say thanks to them, and I look forward to all of your questions.
Thank you so much, Dr. Edwin, for that wonderful discussion. We're going to go into our final talk from Dr. Mfwama Kawatu. But before that, I just would like to remind everybody that we'll have our Q&A session at the end of the third talk. So please feel free to type your questions in the Q&A chat box, and then we'll attend to all your questions or comments after this final session. So let me introduce to you Dr. Mfwama Kawatu. She's a pediatric neurologist at the University Teaching Hospital in Lusaka, Zambia. She's the head of training of pediatric neurology in the Zambia College of Medicine and Surgery Specialist Training Program. She's interested in pediatric epilepsy and neurodevelopmental disorders. Welcome, Dr. Kawatu, and you can go ahead with the presentation.
Good evening. I'm going to talk about Zambia and the projects that we've been doing in line with the IGAP in action. I have no relevant financial disclosures. So globally, there's a huge treatment gap in terms of proportion of people living with epilepsy not receiving treatment. Less than 10% are in the high-income countries, while up to 90% live in low and middle-income countries. Zambia is no exception to this. About more than 90% of people live in rural regions of Zambia, and these people have got very little access to care for epilepsy. There are a lot of barriers to care, and particularly some of them may include geographic barriers. As you know, some places may be inaccessible by road due to rains and bridges are washed away. Financial barriers are a huge component of this, and also sometimes most facilities or most families will not recognize epilepsy as a medical problem. This results in stigma to seek care, and the biggest impact is that most of these patients will then present very late to the healthcare facilities. Majority of care provided for epilepsy is done by non-specialists who have limited training on epilepsy management. Unfortunately, this then results into poor outcomes in terms of management of epilepsy and re-emphasizes the belief that epilepsy is untreatable. The Intersectorial Global Action Plan on Epilepsy and Other Neurological Disorders, IGAP, coincided with some of the action that Zambia tried to undertake to help to take care of people living with epilepsy and other neurological disorders. So in 2020, when the draft was presented, Zambia graduated its first cohort of pediatric and adult neurologists. This included 6 doctors, 2 pediatric neurologists, and 4 adult neurologists. This training was done by one person who was local faculty, and we had multiple visiting international faculties. The training included lectures, bedside teaching, and didactics. After 2020, when COVID happened, most of these lectures were done virtually using virtual platforms, but this did not deter our aim to improve neurological care in Zambia. And so we graduate between 2020 and 2023, we graduated 3 more neurologists. And currently we have 10 neurology fellows in training. 7 will be graduating in 2025. Of these 10, 2 are from countries other than Zambia. One is from Tanzania and the other one is from Liberia. Another milestone that we have made in terms of our neurology training is that we have established local faculty in the adult neurology program and also the pediatric neurology program. So the pediatric neurology faculty includes 2 pediatric neurologists and 1 epileptologist. The 2 pediatric neurologists are stationed at the Tertiary Hospital in Lusaka, UTH, and the epileptologist has got scheduled visits throughout the year. We train not only the pediatric neurologists, but also pediatricians in training. So the journey of pediatric neurology has been long and wide, but particularly in epilepsy, in addition to the training that we've done, we have 1 pediatric neurology fellow currently, and we hope to graduate 3 more by 2024. We have multiple engagements with the community where we train community health workers, we train doctors and nurses in the rural health settings, and this has been done with a lot of collaborations with various partners. To begin with, I'll talk about the training for non-specialists, which has happened across Zambia. The pilot training was done in Lusaka, which is the capital city of Zambia. And from that training, we learned a lot and improved, and then later on extended this 5-day interactive training to other provinces of Zambia, including the Copperbelt province, which is somewhat north, south and southern province. This program includes multiple levels of non-specialists based on the initial pilot for Lusaka. There's an increased practical application and direct clinical training on epilepsy. And The focus of this training is on repetition. We use cases and incorporate practical sessions with patients and role playing amongst the healthcare providers and also the patients so that they have a hands-on feel on managing of epilepsy. The 3 rural sites were selected together with the Ministry of Health, which helped to also identify the team at the local second or third level hospital for strengthening of referral systems to the tertiary hospitals. The training also included a 1-day workshop, which is provided at a referral hospital on the epilepsy basics. After, as part of the community healthcare worker training, we did an evaluation of the training, and also we wanted to also see how well our validated questionnaire was working in this training. So the conclusion of that evaluation was that there was a successful impact with the 5-day program, which was focused on practical applications. It made people more confident in taking a pediatric seizure history and doing a simple examination, and also the understanding of the key elements for good epilepsy management in children and retention of the knowledge in the short term was increased, and it just showed in how confident the community health care workers were in terms of management. From the community health care worker trainings, the community health care workers in Zambia not only go to the community, but they act like an intermediate between the hospital and the community. So the most striking result was that the training helped to intervene in some of the matters that arose from taking care of children living with epilepsy. They were able to intervene by ensuring that medication compliance was there. They would advise families on when to return to the clinic, and they would also help establish who needed a referral to the University Teaching Hospital, to the pediatric neurologist, which is the University Teaching Hospital is the highest tertiary hospital in Zambia. And of note is that on average, the disabling seizure frequency dropped from about 2 per week to about 0.4 per week after 12 months of implementation of this training. Collaborated with the project Educare, which is a faith-based organization that takes care of children with various disabilities. So this project was over 3 years. The first year was to train community healthcare workers, doctors who were non-specialists. These doctors are doctors who are pediatricians in training, registered nurses, and clinical officers. This training started in September 2022. So this was a 5-day training from 29th August to 1st September, which included both didactics and practical sessions and role playing in the identification, treatment, and management of epilepsy. From this training, a clinic was set up in January 2023 at the Chichetekelo clinic, and this clinic currently caters for both adults and children who are living with epilepsy on the Copper Belt. There was a 3-day follow-up and review training session, which was done in March 2023. And at these sessions, we had another practical session, including those cases that the primary healthcare providers thought were difficult cases. So they brought them to the review and follow-up training, and we went through the training together. And this helped also build capacity in some of the patients that are drug resistant, that are living with drug resistant epilepsy. So that is the team of the doctors and nurses and healthcare workers that have been trained in epilepsy management. Apart from this, apart from the trainings that we've done, we have also managed to launch the pediatric epilepsy training in partnership with the British Pediatric Neurological Association. So the PET training was launched in May 2023, and it included training of faculty from Zambia and Zimbabwe. So we trained a group of doctors, about 28 in total, from Zambia and Zimbabwe. The Zambian faculty included a nurse practitioner who is active in taking care of patients with epilepsy. He also works as an EEG technician. So the training was over 3 days. Day 1 and 2 was training of the faculty members, and day 3 was the actual training of other healthcare providers. The health care providers included interns, doctors who were doing their internship, doctors who were in their pediatric training at various levels. It included community healthcare workers, and it also included clinical officers dotted around Lusaka. So the faculty that was established in Zambia included people. There was a deliberate move for the Zambian PET faculty to have at least one faculty member from each of the provinces of Zambia. Zambia has got 10 provinces, and so we had one faculty member from each of the big regions, from Eastern Province, Northern, Copper Belt, and Southern Province. But however, the majority were from Lusaka Province, where we get the bulk of the referrals from all over the country. In addition to this, we had 2 faculty members who work in the adult neurology section. We felt this was important because as we transition children living with epilepsy from the pediatric to the adult service, it's important to have some adult neurologists take over this care of these children. So in the future, we plan to have the PET training included in the pediatric specialist training program curriculum and make it compulsory for all those training in pediatrics to have the PET done. In addition to this, we would like to have another training by March 2024, and this training we hope to have not in Lusaka, but in another region of Zambia where we can train pediatricians, nurses, doctors, and community healthcare workers in PET. So this concludes my the Zambian report in trying to reduce the treatment gap for epilepsy. Thank you.
Thank you very much for very fantastic talks from Professor Charles Newton, Professor Ed Travertan, and Dr. Mfuama Kawatu. I think the talks were very informative and very educative, trying to showcase various projects that are happening around the African continent in trying to address the IGAP. So I would like to remind all the attendees, if you have any questions or any comments, please put in the Q&A section, and I'll be happy to address the questions to the speakers. So to start the ball rolling, question number 1 is from Chantal Kanyabutembo, who's saying many in rural area doctors and nurses do not know how to interpret the EEG. So his or her suggestion is the WHO should build a central digital health where a health worker may share the MRI and EEG image and get the exact type of seizure and the child has, and which medication may be recommended, because he's thinking that children who are receiving anti-seizure medications may be receiving with the wrong dose, and that may lead to the child risk of fatal incidents such as sudden death and stroke. So maybe, I don't know, Charles or Ed would like to take this one about the possibility of WHO creating a central digital healthcare where people can upload their EEGs and imaging for interpretation.
I think the WHO doesn't have the resources to do that, to be honest with you, because they're mainly involved in implementation research, public health initiatives, and so forth, rather than specific diagnosis and within. I mean, we do it all the time. We do it in the context of if we've got an MRI scan or an EEG which we're not sure about, then we ask expertise around the world, both in Indian colleagues, as well as in the UK. I think that the over-reliance on EEG, as Ed has already alluded to, the diagnosis of epilepsy is really dependent upon the history, and you don't need the EEG to make a diagnosis of epilepsy. It's getting the history in the appropriate language and culture nuances that is particularly important for the diagnosis of epilepsy. And we see a lot of EEGs which are misinterpreted by people who bought EEGs for private practice and such like. So I think EEGs can be dangerous. We find it useful in the context of classifying the seizure types and also identifying some of the epilepsy syndromes. But other than that, I think that this reliance on getting an EEG in epilepsy, particularly in sort of community-based services and rural areas, shouldn't be emphasized as such.
Thank you very much. Yes.
If I could just add, I couldn't agree more with Professor Newton. I just add, I think this issue of how much emphasis should be placed on EEG and how should ministries of health rank levels of importance, for investment. There's a limit to the finances. So I think one thing that would be helpful for all of us working in this this important area is to think a little bit about some of these issues that Professor Newton has mentioned. We know EEGs are needed in some situations and are helpful. In other situations, it can be harmful, as Charles has pointed out, and I think we've all seen that. But we really don't have good data, even in high-income countries, to show in what situations does EEG really make a difference in terms of outcome, and that hasn't, I don't think, been well characterized in the African continent. We've just for our SEED project, which I didn't really mention very much, which is really a status epilepticus a cohort in which we're phenotyping about 1,500 children with status epilepticus and looking at clinical and genomic predictors of outcomes. So we had one EEG tech in a city, about 4 million people, which obviously is inadequate. We trained 14 more EEG techs for the Bridge project recently, and are doing EEG and EEG video for our research, and now doing a little more in practice. But so the business of and the investment in training EEG techs that would be required to scale up EEG significantly is going to be enormous. And then what's the trade-off between that sort of investment and investing in things like the PET program, where we're training physicians and making the diagnosis is going to have to be balanced at some point, but an issue I think that's important for all of us to think about.
Thank you so much, Professor Treverton. So our next question is from Adam Jane, who is the president and co-founder of Epilepsy Support Foundation, I think from Gambia. He's saying the Gambia is among the countries in Africa with not a single neurologist practicing in the country and one neurosurgeon consultant. With a population of 2 million, he believes similar projects mentioned here today can really impact lives and livelihood of children with epilepsy. So his question is the SEED and Bridge project still ongoing? And if yes, how can we register interest? And if no, is there any other projects that Gambia can benefit from? So I think this goes to you, Ed.
Well, thanks. So those are good questions. Both the SEED and the Bridge projects are actually research projects testing, various SEED is really a study looking at clinical and genomic predictors of status epilepticus outcomes, including the development of epilepsy among children who experience status epilepticus as their first seizure. So it's really more of a pure research project than a project on scaling up epilepsy care. Although I think some of what we're learning in the SEED project could help, addressing scaling up epilepsy care and addressing the diagnostic and treatment gaps. The Bridge project's also a research project that's funded purely for northern Nigeria, and we can't take care of everybody in northern Nigeria. So I think the question really is in Gambia, is there a need for scalable service projects? Then those would be things that I think would need to be developed and built upon some of the research that has been discussed today. But there's certainly been some fabulous projects in other areas. I think of the Gates Foundation BedNets project, in the Gambia years ago. So you have a rich history of implementation there. But I think, talking with some of us individually and will probably something that could help. But the Bridge project is technically a research project, so not something that we think is scalable. I think developing a scalable system model is one of our goals.
Thank you so much. So our next question is from Angelina, who's asking that she's surprised that over 90% of treatment gap was found in your study. So did you encounter any resistance in the community fueled by stigma? I think this is also to you, Ed.
Yes, well, we too were very surprised at the treatment gap. Anytime those of us who are physicians, I think especially in public health people that are very busy, it's easy to assume that you're seeing everybody, because you're working so hard in your clinics. I think that was the case in northern Nigeria. But until you actually go out into the community and search, and rather than just ask people to come to the clinic, you just really can't know what the true treatment gap is. And I think your second question illustrates one of the reasons, and that is that the stigma and the misinformation about epilepsy is a barrier, one of the barriers at least. Extreme poverty, transportation problems, and so forth are other barriers. But there are barriers of getting people to diagnostic facilities, clinics, hospitals, is just enormous. And what we found mostly in northern Nigeria is not so much resistance, but just a lack of information. And despair. I think people in extreme poverty are living in despair. And when they're given the opportunity, for treatment for their children and given the correct information, and the information comes from people in their local community that they trust, not people like me, but community health workers who live in their community, we're finding that people tend to respond very well. So we are with you in being shocked at the magnitude of the problem. But my suspicion is if you actually went door to door in many communities and did vigorous screening, I think we'd probably find that the treatment gap in many areas is considerably higher than we've thought based on clinic estimates.
So another question is from Nimin Keshek. This is to Professor Newton. Says, great work from Africa Group. In your opinion, how can we start a project about magnitude of epilepsy and anti-seizure medication adherence, as any epidemiological study is very costly and needs a huge project? I think this is for you, Charles.
Okay. Yeah, so I agree. These epidemiological studies are very expensive, and they're often research orientated, so they need funding from large research organizations as such. I guess the most important thing that I would suggest is that when you're looking for adherence, is to look at the barriers of people obtaining the anti-seizure medication. So where do they fall down? Is it because the cost of getting to the clinics in order to get their prescriptions, and in particular to get their renewal prescriptions? So for example, in Kenya, we started off, the government used to only give 1 month supply of anti-seizure medication. We've now convinced them to give 3 months supply. So it reduces the cost of the frequency which people can have to come back to the clinics in order to do it. Getting the medication out into peripheral clinics, so they don't, in the primary healthcare centers, they don't just have phenobarbital, but they also have other drugs such as carbamazepine or sodium valproate, if patients are on that. And the other thing is, so not only the cost, the time, because you've got to work out that if a mother is going to take a child in to a clinic to get the medication, that means that she can't work on her shamba, on her farm, and she may lose money if she's not able to go to a market or whatever. So it is quite costly for the parents and the families of people with epilepsy in order to maintain getting their medication as such. We're hoping that the SMS messaging trial that we're conducting at the moment will provide some answers that will be applicable in some areas of sub-Saharan Africa,
and not all, because I know that the mobile coverage is not as great as it is in the sites that we're working in at currently. But I think really the barriers of why people don't access the anti-seizure medication is critical. And the other big thing is the stockouts. So what we have is the problem where a lot of our clinics run out of medication. So a patient comes to the clinic to get the medication and finds there's none there, and then they've got to come back in 2 or 3 weeks' time when the medication is meant to be there and find. And that's really disheartening and a real barrier to adherence. So those are the issues that I think I would look at initially, which are not very expensive.
Thank you very much, Charles. I think we have all the answers in the chat box answered. I don't see any other question. Yeah. Any closing remarks? No more questions?
Could I ask a question of Charles? It may be a question others have, but one of the wonderful aspects of your really great presentation, I think, was the way you framed what we all too often refer to overly simplistically as the treatment gap, when this is really, there are multiple types of gaps and that we need to address, diagnostic gap being one. That's the one that's been the biggest hurdle for us in northern Nigeria. But then the adherence gap, your wonderful trial on that. Can you talk just a little bit about how you come to thinking about it in that model that you've described? And where do you think in most communities, I know all the different communities in sub-Saharan Africa that we're talking about, they're all a little different. So it's not possible to just take a solution from one community and put it into another place. But can you talk a little bit more about how you've evolved in your thinking in that model? And what are the specific gaps that you've identified where you think there's still the greatest challenges in conceptualizing potential solutions?
Thank you. So I think that one of the things that we did fairly early on is that we had an anthropologist who went out to look at what happens when people develop a seizure within the community and what their pathway to care was. And so in Kalifi, and in fact, all the other sites that I work in, most people who have a seizure will go to a traditional health practitioner first and foremost. And that will be the first port of call. And it's only then, if it persists, or if the traditional health practitioner has a good relationship with biomedical facilities, will they be referred to, or the patient and the family will then say, look, this is not working. We need to find another way of treating these episodes and such. So it was the pathway to care, which was really quite informative. And we had an American anthropologist who came and spent 2 years with us, lived in the community, worked with the traditional health practitioners, identify people within the community who had seizures, and then follow them through to see what was happening to them in that context. And I think that was probably the most insightful thing that we did. And as a result, we then decided that we would try and do collaborative work with traditional health practitioners, which we are doing, and we're still continuing to do in that context. Then the second thing is that, we began to realize that, the so-called treatment gap that, Minardi espoused to in the 1990s was more complex than we had originally thought. And so that's why we began to divide it up into the steps of the diagnostic gap, which depends very much on public awareness, community awareness, that this is a condition which can be treated, can be managed. There are simple drugs and so forth. And the problems with adherence, which had different risk factors from the diagnostic gap, which was Caroline's work. And then to begin to work on those risk factors associated with the two different main components as such. The only other thing that I would mention that we did also learn was that the traditional health practitioners provide quite a significant amount of psychosocial support, which is not found in the biomedical facility. So when Nat looked at the relationships between the people with epilepsy and what was happening at the clinic and what was happening with traditional health practitioners, there was the reason that the traditional health practitioners are so successful is because they provide an explanation of the epilepsy within the cultural context. They spend a lot more time with the person and the family, and in the places where where payment is required for the biomedical facilities, for example, the traditional health practitioners were able to have much more flexible payment things. So they were often paid in kind, such as chickens or goats or whatever, and their payment plan could be over months rather than a cash thing to be seen by a doctor in a private clinic and so forth. So there was quite a big difference in the sort of quality of engagement that occurred between the two different systems. And we have a lot of patients, including some nurses, who will go to, for example, they'll come to our clinic for their treatment of epilepsy, but they also go to hay fevers and so forth. And they believe that they need to have both components and in order to manage their epilepsy in this context. And this we found not only just in rural Kenya, but also in rural South Africa. It's found in urban Nairobi, and now we're finding it again in urban Accra. So it does seem to, there are differences, and there are different treatments, you know, in each of the different communities, but the underlying theme is the same, is that people will often use alternative sources rather than biomedical facilities for their treatment of epilepsy.
Thank you very much.
Yeah, thank you so much, Charles, for very insightful inputs. And I would say the faith healers is something we also see the same here in urban Dar es Salaam as well. So it's something which is becoming more and more prominent. And what we are seeing, it's regardless of the level of education, people will still go to these places. Any other questions or comments? Okay. No questions from anyone, comments? We still have a few minutes. We can finish early. Okay, so if there are no more questions, maybe I should welcome my co-chair, Dr. Nalucha, if you have anything to say before we close up.
Not really, just to thank everybody for joining in the session, and I hope we have an understanding of the IGAP and in the various countries from which our participants are from. Hopefully we can have more projects towards the IGAP implementation.
Yes, so thanks everyone. Thank you, our wonderful speakers, for very insightful and wonderful talks. I think we've all learned a lot. And thank you all the attendees for taking our time to attend. I hope you've benefited from the fantastic talks and you've learned about the various projects that are happening around the African continent. So look forward for the next EpiSkills, which is going to happening soon. So you'll get the adverts from the ILAE. And I'd like to thank everyone once again and wishing everyone a very good evening. Thank you so much and bye-bye.